Welcome everyone to this webinar of the Venous and Lymphatic University. I really want to thank everyone for joining us. I think Dr. Rosbath and I were talking about these topics. We thought this was one of those that was very important because I feel that one of the biggest challenges that we have in our field, in our specialty, is that there is no single clear pathway for us to train as vein specialists. For us who really feel passionate about this, there's no clear training pathway. And so I'll put this together piece by piece by clinical experience and doing the cases and platforms like this, maybe some mentorship, for those of us who've been blessed to have mentors along the way. And so it is really important to have this conversation about how this happens globally, because we know that it's different everywhere in the world. And so that's why we wanted to invite our guests. We're going to be hearing Canada, from UK, from Colombia, hopefully from Mexico as well. And so it is, the goal is very simple. It's just to share the perspectives everywhere and hopefully create a more clear pathway moving forward for those who want to join our specialty. So thank you so much, all of you guys, for being here. And like I already said, we have an outstanding international panel. And so without further ado, I want to introduce Dr. Bar, Meredith Bar. She's from Canada, and she's here and ready to go. So take it away, Meredith.
Thank you. So hopefully everybody can see my screen. I am a vascular surgeon practicing in Toronto. I've been in practice for nearly 2 years. So I'll try to provide some perspectives from Canada and specifically our region, as well as how it compares to the US. But I think all of it really starts with looking at what our health systems look like, and it's quite different between Canada and the US, and sometimes being right next to the US actually highlights some of the ways that we can do better and some of the things that we're doing really well. In Canada, we have a single tiered or universal health system. And in our hospital systems in each province, I would say at least 90%, if not more, of the time and resourcing that we're allocated goes towards treating arterial disease, whether that's aneurysmal disease or peripheral arterial disease. There are huge initiatives towards limb salvage and recognition of aneurysms, preventative screenings, things like that. But what ends up happening is a lot of the venous pathology does fall to the wayside or is viewed sort of culturally as cosmetic more than it is medical. As far as deep venous treatment in Canada, I would say it leans heavily towards being conservative management, and oftentimes these patients are referred to medical specialties like hematology or followed along by family doctors. Rarely is it ever intervened upon. No specialized centers exist, but there are some interventional radiologists that do these interventions, especially endovenous interventions. But the patients, unfortunately, are not really followed that closely, and it's quite disorganized, especially in our region. As far as superficial venous treatment, we do offer vein stripping in hospitals. Here in Ontario, there are specific criteria that patients have to meet, whether that's symptomatology despite a trial of compression or lipodermatosclerosis or ulceration. Otherwise, they don't qualify to have vein stripping in hospital. So their only option would be an endovenous ablation or sclerotherapy in a private clinic. This kind of contrasts to the US, where there is a two-tiered health system, and there are, as far as I understand, incentives and resourcing to treat venous disease. Oftentimes it is managed by vascular surgeons, much more so certainly than Canada, where there are only a few vascular surgeons that will see veins and very few who will make it the primary part of their practice. And that means that it can be treated more aggressively, as well as that it can be referred to specialized centers if needed. Superficial venous treatment, it seems, is more accessible, especially endovenous ablation. And as far as, you know, when I've had talks with those that practice in the US, vein stripping is exceedingly rare. But please, anyone from the US, correct me if I'm wrong on that. I think this really boils down to creating a lot of impacts in training. And in this sense, actually, Canada and the US are quite similar in that trainees get very little exposure to venous disease and venous treatment during training. So in Canada, arterial pathology and treatment is the real primary focus of residency or fellowship training. There is very, very little exposure to venous pathology, either clinically or operatively. And really, unless you seek out working in a private clinic and somebody trusts you enough to allow you to work in their private clinic, there's no time or sort of support to pursue additional training in treatment of venous disease during training. And then what happens after training is there is also very little support to do any venous work in hospitals. And because we have a single tiered system, the only option would be to start doing this in private practice. And a lot of people will admit they kind of teach themselves. It can be highly, highly lucrative because it is paid for out of pocket by patients and there is a demand. But I find a lot of people view it as sort of a side gig. It's not their main focus, and there's very little motivation to do it really well, aside from a few individuals that are doing an excellent job and are really passionate about treating venous disease properly. In the US, the same thing happens, I think, in a lot of training programs. There's a huge focus on arterial pathology and treatment with minimal exposure to venous pathology. After training, however, I think vein specialists are quite valued and people finally understand that this is a really important part of being a vascular surgeon. So we come to the same outcome, which is surgeons realize they really should have been paying more attention to veins all along because it affects a huge volume of people and there is a demand for being really good at treating venous disease of all shapes and forms. So I'm very early in practice and I'll briefly discuss some of the things that I'm currently doing, and certainly I'm quite open to the rest of the panel where everybody has probably more experience. But I think one of the most important things that I did early on when I was at the end of my training was I tried to get as much experience and exposure as possible. So I'm always open to seeing anything. I'm quite open about my interest in venous disease and in lymphedema. And I say, you know, send me these swollen leg referrals, send me wounds, send me lymphedema. And a lot of these things in Canada, people don't really want to see in huge volumes anyway. So they're happy to send my way. And it's really a win-win situation. I think the other really important thing is to be honest with yourself and with patients about what you can do. I'm still in the process of learning and I'm doing everything that I can to level up. But I also can't put patients in harm's way because I want to try some really fancy endovenous recanalization that I haven't done before. It's important to have support at your institution, but also operate at your comfort level and probably level up slowly over time as you learn. Finding great mentors is key. I think everyone who is interested in venous disease would probably say this. It's an exceptionally warm and welcoming group with zero intimidation or anything. People are always happy to teach and discuss cases, which I think is so incredibly important. And people are always looking to support those of us who are starting out and developing our interest. Attending conferences, reading books, looking up cases, looking up case reports for things. Always learning is important for anything, but especially for practicing in venous disease because we get so little exposure in training. It's kind of like starting from scratch. One thing that I have learned is incredibly important is investing in your team members and in your relationships, both with other physicians and also with those of us who work with, you know, administrative support staff, with nurse practitioners, with ultrasound technologists. Those people are the foundation of any venous practice, and finding really good people, recruiting really good people is paramount to having any type of successful practice, whether that's, you know, clinically and medically focused or if it's more cosmetically focused, even down to your administrative staff. I have an exceptional and organized and friendly administrative assistant, and she makes a huge difference in my quality of life and how my patients feel. So it's important to have really good people around you and invest in those relationships. And finally, considering specialized fellowship training, I think is important, especially looking internationally. There are very few formal fellowship opportunities, but they do exist. And if you do these things, like I've been doing this for almost 2 years now, and you realize it's your area of interest, then pursuing that and really investing in yourself can make the biggest difference in leveling up to being an expert level. And I'm excited to say I'm actually at this stage. So I'm going to be starting a fellowship in the fall of this year, internationally. So I'll be able to learn even more about this area that I'm really interested in. Happy to take any questions and kind of discuss everything with the panel. Thanks, everybody.
Thank you, Meredith. That was a beautiful presentation. And I love hearing, we don't necessarily, we didn't want to have people who are extremely experienced. Like, it's beautiful to see this from your perspective. So thank you for sharing that. I agree that I think what you compared of Canada and the United States is pretty accurate. I think for us, vein stripping is like a thing of the past. Like, we don't even talk about that much. And yeah, the access is absolutely different. But I think one of the things that you noted or you mentioned was the like culturally how vein disease is seen, right? As far as like, is this just a cosmetic thing, and is this even important? Which is some of us who do this, because we obviously understand it is not just a cosmetic issue, but for the other physicians and practitioners that are taking care of the patients, that are usually the first line who see them, and who should be hopefully sending them to people like us sooner, so that we don't see them. I mean, it just breaks my heart that we see patients being referred for an ulcer when they should have been seen years or probably decades before, right? But there's such a big gap in terms of the education and the understanding of this pathology. And so I think that's very important. And then the other thing that you mentioned was sort of like the motivation of the people who do this, because yeah, I mean, it seems like it's low hanging fruit. If you can just, do a few procedures and have patients pay out of pocket for them. I mean, obviously, and especially here where I am, Florida, there's very little regulation, and this is the Wild West with patients who were really meant elsewhere. And so I think it is very important that we kind of try to advance this field, and that one huge part of that is training, right, and education, and getting people appropriately trained. So I absolutely agree with you. Does anyone else have a comment before we move on? I would love to share and have more discussion about this. So let me see if I can share her presentation now. Please let me know, make sure that you guys can see it. Hold on, Jose, do you think you can mute your microphone or thank you? And you guys are you guys, I'm getting some messages saying no audio. I've been hearing the entire time her presentation. Can you guys hear it or not? Can somebody let me know if the audio is...
No, it's not working, Lina. It's not working.
Yeah.
Huh, that's
We hear
interesting.
you.
Huh, that's quite interesting. Oh, because I'm playing it and it sounds perfectly for me. Victor, do you have any advice on how to make this?
I'll speak to Victor. Why don't you move on?
Yeah, let's go ahead. Yeah, let's go ahead and do that because I'm not sure. I mean, I this entire time I was thinking that you guys were hearing what I'm hearing of her speaking through her presentation. So I do apologize about that. Thank you for letting me know. So I'm going to stop sharing the screen, and then if we can have Dr. Padaria give us his insights.
Okay, hi.
He is a cardiologist and vascular specialist from Mumbai. Thank you so much for joining us.
Thank you, everybody. It's a pleasure to be here. So, I get the gist of what we are trying to discuss, and I'll, in the next few minutes, tell you what the situation is here in our part of the world. You see, in our country, which is a very large country, about 1.4 billion people, there are only about 1,000 vascular specialists who are trained as vascular specialists. So, they complete a basic medical training for 5 years, then 3 years of general surgical training, and another 2.5 years of vascular training. But overall, we have around about 1,000 to 1,100 all over the country. As far as these vascular surgeons are concerned, their main focus of training up to now has been basically arterial disease. And veins has only come into the picture in the last about 8 to 10 years, where they are taught various interventions, whether they are superficial interventions or deep venous interventions. As far as the treatment of superficial veins is concerned in this country, uh, the vast majority of that is being currently done by interventional radiologists, then vascular surgeons, a few general surgeons, and cardiologists. In fact, I'm an interventional cardiologist, and I actually started the superficial venous ablation program in this country about 25 years ago, 24 years ago, actually. And As far as doing venous interventions is concerned, we also have some challenges here. We all know that for doing superficial vein interventions, we need ultrasound. But in our country, uh, only radiologists and cardiologists can do ultrasound. Even surgeons or gynecologists or vascular surgeons cannot do ultrasound. That's the rule in our country. And we've tried to circumvent this by doing ultrasound training programs for vascular specialists, gynecologists, cardiologists. Cardiologists don't need it, general surgeons, and give them a certificate so that they get the permission to buy an ultrasound machine and do their procedures under ultrasound guidance. The only other option they have is to get a radiologist to work with them in conjunction while they are doing their interventions, which I don't think is a very great thing to do. Now, having said that, a lot of people who are doing interventions just start doing interventions because doing an intervention by itself, especially a superficial intervention, is not a matter of great skill. You can cannulate a vein, you can ablate a vein, that's okay. The important thing is to know when not to do a particular case and how to do a case. And for that, you need a lot of background study and information and academic training. And I was very impressed many years ago by a course which was run in the United States under the auspices of the previous American College of Phlebology. They used to run a training course and then used to issue a certificate. They called it board certified, but obviously it was not board certified. And although I was an Indian citizen and not trained in the United States, I did manage to give that examination. And I found that very, very interesting and very useful. And we tried to get that same program into our country for certification locally, mainly for the medical legal point of view and also for the academic background point of view. Unfortunately, the ACP wrapped up by that time. And so that fell apart. But I believe that that is the way to go. You need a very strong foundation in knowing about the anatomy of veins, the physiology of venous disease, most importantly, the how to do ultrasound. And because if you do ultrasound yourself, then that's a very, very good way of taking your superficial venous ablations forward. And the actual procedure of and the equipment, I think one will learn over a period of time. That's not something where it doesn't require too much of rocket science. The other important aspect is deep venous interventions. Now, deep interventions nowadays in our country are mainly done by interventional radiologists. But again, few cardiologists like myself, I started doing deep venous interventions like catheter-directed thrombolysis way back in 1991. So we do have some experience, started using urokinase at that time and streptokinase, which was available, drugs we probably may not even have heard of, and doing just balloon angioplasty of the veins at that time for occlusions. Of course, we've come a long way through, but these again require a lot of skill, a lot of proper training. And we do now in our country have around 3 or 4 centers where this training can be offered. But again, if I say 3 or 4 centers, every year they take only 2 candidates. So only eight candidates in the whole year in a country of 1.4 billion. So we do have our challenges. A lot of people are now doing sclerotherapy because I still think that for the masses and for financial reasons, sclerotherapy is cost effective, even if it's done again and again. The person who does not have much of a financial clout can afford it and at least get some relief. As far as thermal ablation and glue therapy is concerned, it's pretty expensive in our country. We do have some degree of medical insurance, but there's no state-sponsored insurance. It's all private insurance. So in the metro cities, it's fine, but for the vast number of the population who are not in the metros, it's a difficult option. So stripping is still done by general surgeons, although gradually, I'm sure in the next 8 or 10 years, that's going to disappear with lasers and other modalities being more cost effective. Another great leap we have taken forward is basically making all this equipment ourselves. For example, our local indigenous companies are making our own laser machines. We will also probably in the next 3 months be launching our Indian glue, which is going to be slightly different from the Venous seal and the Turkish glue. So that should be another step forward. We make our own stents. We make our own balloons. We don't yet make IVUS, but I think that is just a matter of time. So with local manufacture, costs go down. And as you know, in venous disease, the most important thing is costs. I was listening to Dr. Bar from Canada talking about late presentation of patients. That's something we face all the time. In fact, you'll be surprised that in my practice, I do about approximately between 1,000 and 1,200 endovenous thermal ablations a year in my center, which is a single physician center. But then I have 8 or 9 nurses who work with me. So we do quite a number of cases every day. So in our practice, which is a private practice, almost 20 to 25% of patients will actually present with C5, C6 disease. So it's a very late presentation. And so we also have to have good wound care management at the same time while we are doing our venous interventions. So in summary, I would say that our situation is slightly different from that in the Western countries. We are still struggling to get to where you are, mainly because of our financial reasons and logistics. But yeah, with indigenous manufacture of equipment and making products cheaper, I think we'll be able to reach out to a larger population. What we will need in the future is help from international societies like the VLU to help spread the academic information amongst our doctors. Because I personally think that the more the doctors know, the more they'll be able to tell their patients and convince their patients about getting this treatment done early. Thank you very much.
Thank you. I appreciate shocked to hear about the whole ultrasound situation. I cannot imagine a world where vascular surgeons cannot do. Rebecca, you ready?
Yes. Hello to everybody.
Yeah,
I
thank
have
you for
some, yes, I
joining
have some
us.
issues, but always your cell phone, it's better sometimes that your laptop. So I'm here finally. I was shocked too, but I guess we can have some
Yeah, I agree.
news at the end to talk about
Awesome.
it. I want to present now Dr. Jorge Ulloa. He's a vascular surgeon. He is a vascular surgeon from Colombia. He's a very close friend of us. He is an expert in venous disease and in all this kind of issues when we want to do some veins. And besides that, he's a very good teacher about this. So I'm very proud to introduce him. So thanks, Lina, for inviting me. And Jorge, are you ready?
I'm ready. I have just short comments about this. Shoot it on.
Okay, at the end we can talk a little bit about it. Okay.
I'm all yours. I'm
So
here.
the screen is all the screen is all yours.
Thank you. Lina and Rebecca asked me about the experience that we had here in Colombia. Colombia, it's a country that it's located in the deep north part of South America, and it's very close to Central America and very close to the United States and Mexico. We get the best from the south, the best from the north, and it's a very particular and privileged location in terms of not only commerce but also knowledge. Whatever it comes from the south, which is or was a very huge influence, Brazil and Argentina in the last 40 years regarding venous diseases. Now we are getting our information coming from the north, from the United States and Canada. venous diseases is not a strong part of the pensum of what a vascular surgeon is learning in the process. We are just starting to have integrated programs. So in order for you to become a vascular surgeon, you have to do 4 years of general surgery and then 2 years of subspecialty in vascular. From those 2 years, I would say that not even at 20% of the exposure that a vascular surgeon has is devoted to venous diseases. And from that 20%, I would say that around 80% of that exposure it's into deep venous diseases. Therefore, the training that a vascular surgeon has to achieve in our environment, in our geography, it's a little self-made. They have to look for mentors. They have to look for special rotations and get their information from places that sometimes are, or most of the times are outpatient clinics devoted to private practice where they can see and put their hands on laser, radio frequency, or other types of technologies. The deep venous system, it's most of the time approached in the hospital scenario, which is the public hospitals, but the superficial relays into, if you're talking about endovascular, it goes into the private practice. If you go with the regular options that a patient has in the system, the health system, it's the old-fashioned ligation and streaming. Yes, it still exists. Yes, it is maybe 90% of the options that a regular patient has in the system, it goes into this. And only a 10% of those look for a different option that most of the time goes into the private practice option. The numbers are not as much as those numbers that you see and you find in the United States, Canada, or maybe Mexico. We're talking about a private practice, kind of the same that Shoaib Padaria has in India. It could achieve a number close to 10 cases per week. It makes 80 cases per month. And in 11 months of work, you do the math. That's what we have here. Those are the options. Yes, we do have endovascular options. We do have all the spectra of lasers. We have the 3 or 4 options that you can find in market in radio frequency, and the 2 or 3 options of blue. And yes, we do have HIFU here. It is something that we will address in the near future when we have numbers to expose what is what I consider is going to be the next the new kid on the block and the next option in venous diseases.
So, Jorge, so
I'm
at
here.
the end of the day, okay. So at the end of the day, you're very tired, I guess. You have a bunch of of work, and like you said, how many of Colombian guys with like you are there? Only
None.
veins.
I'm the only one. None. No, just kidding. But I probably count from the vascular surgeons that choose to do mainly or only or exclusively venous diseases. I would say no more than 15 to 20 in a country of 54 million. So it is still a good practice for us. And what you have to captivate the young fellow is that there is there is a kind of a sexy or sex appeal in working in aortic diseases or carotid diseases or something with high flow and high level of stress and everything that it makes it look fancy and nice and appealing for them. But at the end of the day, it is not that this thing, venous disease, is easy. It is not at all. I hate that word. It is not an easy part. the kind of life that you can make, it can be as easy as you want or as heavy as you want, depends on what kind of options you present to the patient. If you get more into the deep venous system or pelvic system, you're going to find more and more stress you want. If you get into the superficial, you get a lot of numbers and you can have stress also. But the things that when a young vascular surgeon goes out into the market, gets graduated and hits the market, he would like to go into the arterial side, and only after a few years of finding the struggle and the difficulties of the system, the financial difficulties, the dealing with non-doctors part of the equation, is when you begin to consider the possibility of opening an outpatient clinic devoted for venous diseases. Most of the time, what you find in my practice is a lot of people that knocks the door and asks for what I don't have, which is a formal rotation, but it's an invitation. It's just my door is open. I can have you for a few weeks or so, and you can see what we have here. Settle down, and we can teach you from how the concentration of sclerosing it's ideal for certain type of sclerotherapy, a certain type of telangiectasias, to the way of talking to the patient and the software you use and all the non-medical part of it, the financial part of it, which is also something that lacks in the process of education. We don't see anything like that. And you hit the road, you get into the market, and there is a lot of people that handle your money, but you don't know how to handle it. So that is something that I really encourage the program designers to look forward into the things that needs to get deep into the process of not only teaching how to deal with the disease, but also how to deal with the payers, how to deal with insurances, how to sell a product, how to sell an idea, how to convince a patient. There is a lot of spectra in here that needs to improve. There's a lot of room for improvement here.
Perfect.
All right, that was very, yeah, that was very, very insightful. So we're gonna try, Dr. Kapnick is gonna try to run Dr. Onida's presentation now, see if we can make it work with sound.
Hello, everyone. First of all, I would like to thank the Venous and Lymphatic University Organising Committee for the opportunity to participate in this webinar. And I'm very sorry I can't be with you in person online. However, I hope that you find this informative with respect to how to obtain advanced venous training in the UK. I have no disclosures. Now, the first thing to say is that in the UK, phlebology is not a separate specialty. And therefore, in order to obtain all those advanced skills, you must complete vascular surgery training. There is no other route to this. However, once you've completed your basic vascular surgery training, you can certainly subspecialize and obtain additional experience. And I'll mention a few ways to do that. And certainly, as a consultant, you can have a major venous practice. Now, this is just a quick slide on how the clinical training pathway is in the UK. So once you finish medical school, you will then go through national selection for foundation training. And this is really 2 years at quite a junior level to learn how to become a doctor. And you rotate through medicine, surgery, general practice, psychiatry, so a whole load of rotations. At the end of that 2-year period, you may decide that you want to do core surgery training because you want to commit to a surgical career. That is an additional 2 years that you get into through national selection again and rotate through different surgical specialties. So ranging from orthopedics to neurosurgery to vascular surgery, potentially. In that period of time, you also have the opportunity to undertake taster weeks. So if you perhaps have not been allocated a rotation in the specialty that you may be interested in, you can do a week or a couple of weeks exploring that specialty, which is very helpful in deciding then what to apply for. But if you decide that you want to apply for vascular surgery specialty training, then again, that is national selection. And if you get in, you have another 6 years to look forward to of early, intermediate, and final training. And here is where the bulk of the information comes from. There's specific portfolio that has certain milestones that need to be achieved at every year, and those are reviewed annually at the annual review of competencies. And as part of the curriculum, you have a number of procedures that need to be able to be performed at consultant level, so being able to do them independently, but also being able to deal with any complications. And you can see here the list. And for venous disease, what you've got is varicose veins, including SFJ and SPJ ligation, endovenous ablation, foam sclerotherapy, and phlebectomy. So obviously it's very superficial venous focused, and also not exhaustive, obviously, in terms of the venous curriculum. So if you want to have further experience and additional skills, for example, in deep venous intervention, then those need to be sought out independently in a way. At the end of your training, if you have full General Medical Council registration, have passed the exam from Fellowship of the Royal College of Surgeons and completed the training program, then you get awarded your certificate of completion of training. But how do you get advanced venous training? Well, before you get your CCT, you can certainly, during your training pathway, request a rotation in a specific unit. This tends to be in your training region. You can see here London is in yellow. But if you know that there are specific units that are delivering the sort of advanced training that you're looking for, you can certainly get exposed to it over and above what is in the curriculum by going to those specific units. So that's certainly an option, and the training program directors often take your own interest into account if possible, so that's certainly a possibility. You can also go for a pre-CCT training fellowship. What that is you're spending a specific amount of time to develop certain skills in another unit. It can be with competitive entry, so with specific exams or interviews to get in, can be in the UK or abroad, and that year can sometimes count towards your training as long as that has been agreed by the training program director and the training committee. Occasionally you have to take that out as an out of program experience so that your training is then lengthened by a year, but it's certainly a possibility. With respect to post-CCT advanced training, again, you can do a fellowship. So some people finish their training and then decide to spend a year abroad prior to then coming back to apply for a position as a consultant. Another way is to just go for a consultant vascular surgical post, but then be in a unit that perhaps has that advanced venous training that you're interested in, or specific colleagues with expertise in advanced venous management. And in those cases, you can certainly buddy up or be mentored by one of your colleagues to then learn some of those skills and continue the work that is going on in the unit. So that is one other way of doing it. Finally, you can request a fellowship period or a sabbatical. Often you need to fund these yourself in terms of getting perhaps a traveling fellowship, for example, but once that is awarded, then you're able to speak to your consultant colleagues and your unit lead and the hospital regarding whether you can then be excused for a specific period of time to gain those skills and then bring them back to your unit. And they often see the value of that, so that's certainly a possibility. So in conclusion, there are many opportunities for advanced venous training, both before and after your certificate of completion of training. And importantly, you can develop your subspecialty interest even as a consultant. Thank you very much. And I'll be happy to take any questions that are forwarded via email and I can get back to you.
Great.
All right, I'm glad that worked. Thank you so much, Dr. Kaplik, for running that. I'm glad we were able to make that work. So, I mean, I think at the end of the day, and this is just very true for pretty much everything. You know, just there's so many different ways of doing things, but I think the fact that even here in the US, there is no straight pathway into training. I would like to ask everyone just to give their opinions on how do you think we move forward? What do we need to, what changes do we need to impose? How do we make this happen so that there are more clear, straight pathways into training and it's not just people trying to put the pieces together and trying to make it work that way. I would love to hear everyone's opinion.
Hi, Lina. I guess, first of all, here in Mexico, I invite Dr. Erasto Aldrett. Here in Mexico is kind of similar like in Colombia. And, first of all, we have to be vascular surgeons because we don't have here in Mexico, the term phlebologist doesn't exist because it's out of the law because there is no a way of our practice has to be a certificate, board certificate, and they don't have it. And there is no university, there is no program to do that. So we all that do veins, we have to be vascular surgeons. And here in Mexico is a kind of not specifically, but we have only two main programs here where we can go and learn a little bit more about veins. That's why I invite Erasto, because he's one of the professors and that they have the Foro Venoso Mexicano. And the Foro Venoso Mexicano is a special meeting about only veins here in Mexico. So I don't know if you wanted to say something, Erasto.
Hello, everyone. Thanks, Rebecca. Thanks to Bain University for having me here. And yes, my name is Erasto Aldrett. I am the secretary of Foro Venoso Mexicano. As we don't have a formal training in phlebology or vein disease, everyone who does vein surgery or treatment of vein diseases, it's hard to get specialty training. So we in Foro Venoso Mexicano have approximately 3 or 4 courses a year. As a matter of fact, right now I am on a sclerotherapy course that is just for vascular surgeons here in San Miguel de Allende, Mexico. If you want to come, you are welcome. And we organize every year one big, great symposium or congress that we receive approximately 300 to 400 people. 80% of them are vascular surgeons that practice here in Mexico. And we try to give them the most late experiences in technology. We try to have here the most renowned professors in venous diseases. So we try to make this scientific treatment of veins. We also have hands-on courses twice a year where we do thrombectomy practice, we do vena cava filter practice, we do stenting practice. So we try to offer to vascular surgeons the opportunity to get a more specialized and high-level training in venous diseases. As we heard from Rebecca, in our formal vascular surgery training, we don't have very much of venous experience. So everyone has to look for, if they are interested in venous diseases, they have to look for their own experiences, their own training in venous diseases. But the reality is, I heard what Jorge Ulloa was saying, that here in Mexico, we have the same numbers, 80% maybe, or 70 or 80% of of my practice is venous disease. But aorta and carotid diseases and all that is fancy. But that's not the everyday practice of a vascular surgeon. That's the reality. So we try to give them specialized training, and we try to to make the vascular surgeon an outstanding practicer here in Mexico, so they can offer very high level medicine in this area. Thank you.
Thank you, Erasto. It's very interesting because you are the only one who are involved in promote the Venous training and to get the updates years after year in the Foro Venoso Mexicano. So I don't know if what do you think about it, Lina? Because or you, Jorge, because we are Latins. So I just hear Dr. Pradhan about he's a cardiologist, interventional cardiologist, and so doing veins, and so it's strange for us because most of us we are vascular surgeons. So here in Latin America, I guess the thing is that we have to promote how to do veins, how to improve our skills. I don't know thanks to BLU because it's very useful to do at least webinars, and but maybe we can do a meeting or a special meeting like you have in Foro Venoso Mexicano.
Yeah, I think regionally that's very important. I mean, obviously having, meetings where we have people from everywhere in the world are important, but those are a little bit more challenging. So I think those regional meetings are important, like the Foro Venoso Mexicano. I'm actually participating in the Foro Venoso Dominicano from Dominican Republic. So I think it's very important that the vein specialists get together regionally to try to teach, to try to promote education regionally. And then, just while we get there, and just as a general resource, which is very, very handy, is platforms like BLU, like exactly what we have here. Joining this kind of organization, this kind of platform, there's materials, there's lots of things that are constantly being shared on this platform, webinars. And so for those of you who are wondering what you can do in the meantime to try to stay up to date, ahead of the game, learning what's new, learning what everyone is doing, and learning from the best, is try to stay really connected with this kind of platform with Venous and Lymphatic University, so that you can really benefit from all of the materials that are available there. So I definitely wanted to put that out there. Meredith, do you guys have like formal Venous meetings in Canada? Is that something that you guys have?
No, it's in Canada, we're kind of we're quite behind, and hopefully that will be changing in the next coming years. But I think culturally there are a lot of similarities. I resonated a lot with what Dr. Ulloa was saying about how people view arterial disease and aortic work, especially in training and early practice. You quickly realize actually a lot of the venous work, especially deep venous work, is 10 times more challenging, 10 times more nuanced, but also 10 times more exciting because it's a new field, relatively speaking, and we're still learning a lot about it and which devices are best to use. It's also so interesting to hear about some of the devices that are being made overseas, and really exciting that people are starting to design their own interventions. So it's such an exciting field, and I think being early in practice, freshly out of training, it's a shame that culturally, I think in vascular surgery, venous disease is viewed as, quote unquote, easy or not as sexy as the arterial work, because I think it's the exact opposite. And unfortunately, everybody realizes that really late when they're at the end of training or they're entering their consultancy. Dr. Onida mentioned, when you're already in a consultant position, you can go back and do more learning. This platform is amazing, but at the same time, we're also already working and we're already busy. We're making time on weekends. I think it's going to be so important to really start generating interest in venous disease early, start incorporating rotations for residents and fellows, having questions on the exam. 25% of the exam in the US being venous focused is going to really push programs to expose their trainees towards treatment of venous disease and understanding it's not just cosmetic. There is a huge cosmetic component, but there's a huge medical component. So taken together, I think there is hopefully a paradigm shift in the way that venous disease is viewed in the vascular surgery world and in the broader medical world. In Canada, we are just at the very, very start of that paradigm shift, and we're hoping to start generating more meetings and be more involved internationally with this broader network. So right now, more specifically, the American Venous Forum is another great resource in addition to this one that is right next door, and that's what most Canadians connect with. We don't have our own dedicated meeting, but step one is going to be creating a specialized venous day as part of our Canadian society to bring together venous specialists and share knowledge in Canada, as well as promote interest so that we can be part of this really exciting paradigm shift that I think is coming.
Thank you. Thank you for sharing that. And then Dr. Padaria, would you like to tell us a little bit regionally what's happening there? I just think it's incredible that again, just vascular surgeons here, I think, or everywhere else in the world are essentially leading the vein space, and to hear that it's different there, it's quite shocking. So can you tell us a little bit about that? Like how do you guys, or how does a vascular surgeon in India who once truly has a passion for vein disease, how do they do it there? And is that the same regionally in Asia, or is it just in India? Can you share a little bit more?
So first of all, I think we need to get rid of this notion that only vascular surgeons can treat veins.
Of
All
course,
right,
no, and
that
that's
is a
not what I
notion
mean.
that's a notion which should be thrown out. As an interventional cardiologist, if I can do coronary arteries, if I can do carotids, I can do mesenteric arteries, I can do renals, then for sure I can do veins. Similarly, an interventional radiologist is very well equipped to do all veins wherever in the body. What really is needed is the background information of the physiology, the anatomy, and when not to do the cases. And that's most important. So I think the first thing we need to get rid of is who should be doing what. A doctor is a doctor. As long as he's trained in a particular procedure, he is going to be good. This is not rocket science, believe me. All right. No venous procedure is rocket science. You do 1,000 cases, you're going to be set for life. That's number one. The problem in our country, in our region, is that you'll have to appreciate there's something called female infanticide, where female girls are put to death because they are females. And how is that detected? That is detected by ultrasound. Now, in order to stop this heinous practice in our country, only very few people are allowed to do ultrasound under very, very strict regulations. And that's the
Shoaib,
reason why ultrasound is not being allowed to be done by everybody. Correct.
Wow.
Now we have gynecologists who can do ultrasound, cardiologists, they can do echocardiography, so that's also ultrasound, and radiologists. We are now in the Supreme Court of India have filed a petition for allowing vascular surgeons to do ultrasound. They have given us an authority that those vascular surgeons who undergone a formal training in vascular ultrasound will be allowed to do ultrasound, which I think is fair enough. Because as far as I know, in our country, no vascular surgery program has any vascular ultrasound training or ultrasound training at all. So unless that is incorporated into the training program, I don't see how they can do. So that's that. As far as the meetings are concerned and trainings are concerned, every year we run a huge Venous conference called the YCon, Venous Association of India conference. I'm one of the founders of that program. And in fact, I'm running the next conference in March, where the Venous and Lymphatic University, under the chairmanship of Dr. Lowell Katnick, has very kindly offered to have a 1-hour presentation in the conference, which is a virtual presentation. So in our conference, we invite people from all over the world to either come in person or to deliver virtual lectures to us and train us in the most recent advances. We get about 300 to 400 delegates at these conferences every year, and it's a pretty large conference. Apart from that, in our area of the world, which is slightly different, when I say different, it's Southeast Asia, we have something called the Asian Venous Forum. And the Asian Venous Forum is a conglomeration now of around 19 countries which collaborate on a regular basis, sharing information. Um, Information about venous diseases, information about technology, information about equipment. Because you will understand that equipment available from China, from Malaysia, and India is much cheaper and allows us to do much more cases in our part of the country. So, yes, culturally, we are different. The West is different from us. So, we have to tailor our treatments and our method of looking at our patients slightly different. And the type of doctors who will treat veins in our area will be different because we only have about 1,000 vascular surgeons in our country for 1.4 billion people. They can't be obviously doing all veins. It's not possible physically. So other doctors will be involved. And I do hope you guys, all of you, will cooperate with us and help us in our learning process in this field. Thank you, Dr. Kapnick, once again for all your help for our conference. Thank you.
Thank you. Thank you, Doctor. I just want to have a small issue here. The most important, besides to have the knowledge and I guess, is being permitted by the government. Our laws here in Mexico are very clear. Of course, knowing the anatomy and having the training and everything is essential for the patient. But we must also take into account that laws in each country. I know the anatomy I cannot do cardiology interventions because there is cardiology interventions here in Mexico. So it's not only to have the training, it's not only having the knowledge. We have to take into account that the laws here in Mexico are very clear. So that's why we are surprised. If there is no another people who knows how to do it, of course we can fight against the laws. But we have a very here in Mexico we are very clear about it.
I agree with you 100%. Sorry, I agree with you 100%. Laws in every country are different, and laws are made by the people, for the people, depending on circumstances. So your circumstances may be different, my circumstances may be different.
That's true. That's true. I just wanted to be clear about it because
I think we could keep speaking about it for hours, and it just goes to show how different things are around the world. And so it is just very important. Obviously, and that was not what I meant to say, that you are not capable of doing. Of course, you absolutely are, but it's mostly that just following kind of like the regulations everywhere and making sure that we are doing things in the right way. That's really what matters, doing things the right way for the right motivation. So in order for us to be able to do that, you need to create the space where we can train people, whoever is okay to do it regionally, so that they are adequately trained and that they're doing it for the right motivations. And that was really the interest of the conversation that we wanted to have today. Just for the sake of time, I know we could keep talking about this. I just want to thank everyone who joined us today. Again, I just want to invite everyone to join and be very active with Venous and Lymphatic University. There are so many materials, so many opportunities to learn from these webinars from everyone, and just connecting, sharing cases. So please stay active if you're in the path of becoming a vein specialist. We are all here for you. And we look forward to seeing you in the next webinar that will be announced shortly. I hope everyone has a wonderful weekend, and thank you again so much for joining.
Thank you so much. And I don't know, I guess Lowell wants to say something.
Thank you very much. I really enjoyed the webinar, what's of interest is that we have faculty from all around the world, and we all have our own ideas, and that's the beauty of sharing what we have. So Venous and Lymphatic University is really privileged to have the global support. So thank you very much for sharing your opinions, and really, again, we look forward to our next webinar.
Thank you. Thanks, everyone.
Thank you. Bye.
Thank you. Goodbye.